So what do you think when you think about platelet-rich plasma? Does it work? Does it not work? How much blood should you draw? What PRP kits should you use? Is it leukocyte-rich? Is it leukocyte-poor? Does it have red blood cells? What's the platelet dose? Is it 2 billion, 5 billion, 8 billion? Well, if you're looking for all those answers, you definitely have to take a look at this interview with Dr. Laura Rehak. Come on, let's go. Hi, Dr. Lara. I just want to say thank you very much for joining me today and giving us some valuable insights on regenerative medicine and PRP. Thank you very much. How are you today?
Thank you, Oscar, for this kind invitation. I'm fine. I'm very exciting to do this interview and presentation on PRP today.
Awesome. Thank you. What are you going to be discussing with us today?
Today, I want to focus some critical issue on platelet-rich plasma that is basically the platelet dose and the bioformulation. We know that PRP are not all equals. There can be huge difference from one PRP to another. So for sure, we will need for standardization. And so I want to make clear some points on these two very critical aspects.
Beautiful. I think that is a great idea. That is the reason why, I reached out to you. I saw the presentation that you're going to be showing today, and I'm like, this is amazing, So I reached out to you, sent you an email, and thank you for making this happen. Um, if you would like to share a little bit about, your background and your expertise in regenerative medicine and PRP, so our audience can have a little, background about yourself.
Sure. I'm a biologist. I have a PhD in experimental physiopathology. And right now, I'm a scientific director of an Italian company. The name is Athena Cell Therapy Technology. We are developing new cell therapy in some innovative device in the field of regenerative medicine. And I'm also right now the Italian exclusive distributor of Tropocells PRP. I also have a very long experience in PRP. I started to work on PRP in 2002, so long time ago.
You said that you are the scientific director at Athena. Can you share
Yes,
with us what is your role there with Athena a little bit?
yes. Uh, as scientific director, I choose basically which are the uh, new therapy or new medical device we want to distribute as we are a distributor, or we can develop and I also work in a strict connection with university, for example. So we have different new things coming in the next months.
Wow. Okay. Wow. Can't wait to hear that. Is there any specific, area of research that you're currently working on that you would like, to share with us?
Yes, the focus is always regenerative medicine, but in different clinical application. With PRP, we are more focused on orthopedics, sport medicine applications, so musculoskeletal tissue. And with mononuclear cells, peripheral blood mononuclear cells, that is another autologous therapy, we are more focusing on critical limb ischemia and diabetic foot problem. So these are the two
Okay.
areas of our main interest. We also work on some scaffold and biomaterials on the tissue engineering field to see which is the best way to combine growth factor or cell therapy with scaffold as well.
Wow. That sounds amazing, and I cannot wait, to hear more about that. So, thank you very much. So, if we would like, we can start on the presentation. That would be
Sure.
phenomenal. and just have our audience listen to what you have to say. And I'm very excited for this.
So my
Yes.
presentation today's is on the importance of the platelet dose and the bioformulation of PRP, because are quite new data. Okay, so as you can see here, PRP, and we all know that PRP can be very, very different, but we have to focus uh, especially on two different parameters. The platelet dose, how many platelets we really inject in the patient, in that tissue, and the bioformulation. So how many leukocytes we will have, if we have or not red blood cells, and if the PRP we will use, it will be activated or not. All these parameters can have a huge impacts on the clinical effects on our patients.
Yes, those are very
Uh,
great topics to cover.
So, as you can see in this picture, is from a session in aesthetic, not in orthopedic, but it was a PRP industry session in Paris 3 years, 4 years ago now. And you can see here 8 different PRP, same blood, same patient, same blood. So just only looking, it's clear that there are huge difference. So we start with the first issue, that is the platelet dose. Right now, there are an amount, an increasing data that that are suggesting that PRP should contain a clinical dose of concentrated platelet to produce a therapeutic effect. And this dose, it seems to be higher than 3.5 billions of platelets. As how we can know this? Here I want to show you a very, very interesting review from this group, and they make a very interesting comparison and study, because in this graph you can see they compare 25 different clinical studies on PRP on soft tissue, including tendinopathies, tendons, meniscus, and plantar fasciitis, so muscle. And in the black dots, you have the trials with the negative results, while in the blue dots, you have trials with positive results. As you can see, all the studies involving greater those platelets higher than 3.5 billions platelets have generally report more positive results. It seems there is really a cutoff on this.
Yes.
So it's important to know when we are injecting our PRP, how many platelets we are injecting, and if how many blood we need to have the effective dose, and in which way we can, every time that we will treat a patient, to have the minimum clinical effective dose, 3.5, 4 billions to go up.
Yes.
And recently, 2024, we have this very, very interesting systematic review and meta-analysis of data on clinical trials on knee osteoarthritis regarding the dose. And they analyzed 29 studies, and in 28 studies with positive results, positive clinical outcome, the mean platelet dose was 5.5 billion, while in 3 studies with negative clinical outcome, the platelet dose, the mean platelet dose was 2.3 billions. So they observed the same things that we have seen before on soft tissue. So it seems that it's work in this way in each tissue. And here the conclusion of this study that make it clear that to improve clinical outcomes from PRP injection for knee osteoarthritis, it seemed to be related to a greater platelet dose. And here I want to show you some of the recent clinical publication, clinical paper. As you can see, it's from 2021 to now, to this year, to 2024, that are dosing the platelet that are injected, and they are start to correlate the dose with the effective, with the clinical efficacy in different tissue. You will see here in different pathologies like knee or osteoarthritis, or also meniscal tears, or also osteoarthritis on hip. And here are all the study I show you. So in this world, there are some classification we can use, and we are obliged to use when we published a paper. And I believe that one of the clear and the most effective classification so far, or PRP, is this DEPA classification that is based exactly on first parameter is the dose of injected platelets. You can have very high, 5 billions injected platelets up to 5 billions, high from 3 to 5, medium, low, that are under 3. The efficiency of the production, so the recovery rates, the purity of PRP, and the activation process. So it will be important when we are speaking about PRP to understand and to classify the kind of PRP we are using. With this classification, it could be easy.
Yes, I agree. It's a great idea.
Others group that were doing the same things, but they were focusing their attention on concentration instead of platelet dose itself. And also here, and these are a comparison on randomized study. Also here we see that clinical study with concentration factor higher than 2.5, higher than 3, so 3, 4, 4 or 5 times the platelets you have in the baseline in the blood are working well, are not working at all when this concentration factor is less than 2.
Laura, I have a question. Is there a correlation between platelet dose and the concentration? Can you expand on that a little bit? Is there a correlation? What is the difference between that? Because when I first started, learning about PRP, I didn't know how to differentiate that. Can you expand a little bit about that, please?
Sure. I think also I have some slides after on this, but anyway, easy. Concentration are the platelets in per microliter or per ml. So is how many platelets you have in 1 ml of PRP. The platelets dose are the platelets you have in all the volume of PRP you are injecting in the patients. So to go from concentration to platelet dose, you have just to multiply for the ml, the total volume of ml you will inject in the patients. So concentration itself is not cannot be so clear as parameters, because you can have 10 times the baseline, okay, so very high concentration, but maybe you have only 1 ml of PRP with that higher concentration, and in that case the dose will be low. Or
Understood.
you can have lower concentration, but 7 ml to inject, and you can have the minimal clinical effective dose, because you can have more than 3.5 or more than 4 billion platelets injected in the patient. So it's very important from this data to make this differentiation and to be sure on how many platelets we will injected. Also, returning to my presentation, there are lots of papers, published papers, that they still refer to concentration. Here, for example, we have a study on spinal fusion, and the authors showed that a 5-fold increase in the PRP platelets level above the baseline was required to induce a positive outcome after spinal fusion. So, but here we don't have the dose. So we have to, to be more precise when we are talking about PRP on this site. The same things on the analgesic effect. It seems that the minimum concentration requirement is 5-fold higher to 7-fold higher platelets than in the peripheral blood. But again, here we don't have the platelet dose. Then we have another very important issue, that is that the bioformulation, which kind of PRP we are using. We have red cell contamination, we have leukocytes, so we are using a leukocyte-poor PRP or a leukocyte-rich PRP. And it could be leukocyte-poor, better than leukocyte-rich in every clinical application. So there are still lots of questions that are open.
Yes. And then from what I know as well, there's different types of leukocytes, right? So which
Exactly.
leukocytes are beneficial? Yeah,
Yes.
which leukocytes are beneficial, which ones are detrimental, right? So
So
that's a
yes,
very
it's
good, yeah.
it's a very complicated and issue, and lots of new data are coming almost every day in the last 2-3 years on this. So regarding the red cell contamination, is way from easier, because there are really lots of data that are suggesting that ideally the formulation of the PRP should contain minimal to no red blood cells, because they are quite inflammatory. What it happens when I inject red cell, that I have to wait, then macrophages come and digest red blood cell. So I have an inflammatory problem due to the iron that it's in the erythrocyte, that it can make oxidation and that can produce radical oxygen species. And I also have a slower effect, because I need to wait that macrophage digest all these red blood cells. So it seems that it's essential to reduce or eliminate red blood cells in PRP to avoid this kind of damage, especially these in musculoskeletal tissue.
Interesting.
But when we are looking on the white blood cell, on the leukocyte, it's a little bit more complicated. On knee osteoarthritis, there are different also randomized study and meta-analysis that suggest us that leukocyte-poor PRP may be superior to leukocyte-rich PRP. But this is
Dr. Buddha,
fundamentally correlated to neutrophils, really not to all the leukocyte. Anyway.
Got it. I do have a question, if I may ask, please. On your previous slide, the one up there,
yes,
that little that chart that you have, the previous one, where it says no red cells contamination.
Yes.
20. Okay.
The
can
square.
You elaborate? Yes. Can you elaborate a little bit about that? What exactly is the red dose? What does that mean? I think you did an amazing. Yeah, please. Thank you very much. Yeah.
So basically, we can divide all the PRP in 4 big groups. It's a little bit, I would say, brutal differentiation, but every PRP, okay, can be classified in one of these 4 groups you see here. So in 2 groups, you have red cells, would say high red cell contamination, okay? And you have a red cell and you have red cell plus a high platelet dose, or you can have red with a low platelet dose, okay? For sure, lots of red, very low platelet dose, it will not work, or it will work poorly, I would say. So this is probably for what we know, what science tell us is the lower quality PRP that you can use on a patient.
Is that classification? I'm sorry to cut you off. Is that classification in the previous slide that you explained to us with the how they separated from platelet dose in 0.5? I think it was the DERPA.
Yes. It's correlated to that kind of classification. Absolutely, yes.
Awesome. Thank you.
So I mean, when you see a PRP, you just so it's easy to see if it's red or if it's amber, right? From the color.
Yes.
So if it's red, you can have red low dose, red high dose. Why? And when you have, there are lots of PRP that are very red, lots of red cells with a very high dose of platelets. Because when you don't have a separation, a mechanic separation, okay, like a separator gel or some system that can separate during the centrifugation red from white from white cell and platelets, they are all really close because their density is very, very similar. So if you you are using a device that is not able, okay, to separate red from white and platelets, to have high dose of platelets, you will have also red cells inside, together. On the other side, and we have seen that is not the best thing to have red cell contamination. This is quite clear from data. On the other side, you have 2 other categories, amber or yellow, high dose, low dose. And here we are really speaking about the importance of the, at least would say, 4 billion platelets dose to be sure to have a higher probability to have a positive clinical outcome in the patients.
Okay. Yeah. Thank you very much for explaining that. Thank you very much for explaining that. That was awesome.
Okay, so going back to white cells, to leukocyte-poor PRP or leukocyte-rich PRP, on cartilage, on acne osteoarthritis, it seems there are lots of data, randomized study, meta-analysis that suggest us that in this application, Leukocyte-Poor seem a superior treatment over the Leukocyte-Rich, probably due to the neutrophil contamination. And this is accordingly, there is this huge systematic review and meta-analysis that also correlate a better outcome in terms of pain, so a higher reduction of pain and a better function in CNIOHA in leukocyte-poor PRP versus leukocyte-rich. So it really seems that with leukocyte-poor PRP, we have a better improvement in terms of pain and function in this kind of patients at 12 months follow-up.
Interesting. And in this study, I have a question. In this specific, I'm sorry, in this specific study, do they get into detail with which leukocytes are they considered,
not here. Not here. This kind of differentiation on the different kind of white cells, basically neutrophils and monocyte and lymphocyte, is really so the data are coming the last 2 years, not before. Here, this review meta-analysis was 221, was still was still not an issue at the time. Anyway, they also in this meta-analysis see that local adverse reaction appear to be increased in after leukocyte-rich PRP instead of leukocyte-poor injection. So that's the reason why I use the Latin words primum non nocere, do not harm. Okay. And this is another meta-analysis and on only randomized control trials. So very important on 24 randomized control trials and 1,344 patients on osteoarthritis. And it suggests that the analgesic effect was higher in leukocyte-poor PRP. Here we are. Not all leukocytes are the same. Neutrophils and monocyte and lymphocyte are really different kind of white cells. The physiological roles of neutrophils is completely different to the one of the monocyte and lymphocyte. Basically, in the last year, we learned that monocyte and lymphocyte have a great regeneration ability, have a great immunomodulatory capacity. So they are able to work on the inflammation. So exactly the contrary of the neutrophil, they can increase inflammation, they can modulate inflammation, and they can induce angiogenesis and tissue regeneration in all different tissue. And I've been working a lot of this because together with PRP as a scientific director of Athena, we are working on peripheral blood mononuclear cell autologous cell therapy. And I think we'll have very interesting data in the future from this kind of white blood cells, from this specific population. Okay, so for all these reasons, as scientific director of Athena, we chose to distribute in Italy Tropocell PRP instead of others PRP. Basically, especially with this new system that is based on 20 ml of blood, the 22 ml tube, because I believe this is really the latest generation of PRP, because it's have some really unique characteristic. With one tube, you can have a high dose of platelets, at least 3.5, so you can use two tubes to have from 3.5 up. You can reach a concentration of 1 million platelets per microliter. This is important in Italy because also in Italy we have a regulation. We cannot use more than 60 ml of blood, and to be qualified as PRP, we need at least 1 million platelets each microliter.
That is very
So
interesting.
together, that is only in Italy. So I was looking for, a PRP with exactly this characteristic. So
Wow.
with this system, so we will have the high dose, the 4 billion platelets, the million platelets per microliter. We have the complete neutrophil depletion, non-neutrophil, very, very low quantity of neutrophil, so it's a leukocyte-poor, but we still have some monocyte and lymphocyte mononuclear cell at the physiological range. So we are not concentrated them, but there are still mononuclear cells together the high dose of platelets. No contamination of red blood cells, and the system is a vacuum container. The anticoagulant is inside the tube, so we cannot, it's very easy to use. And it's also buffered to a physiological pH. That it's also very important.
Very important, yes. And it
So
also
just
has
want
that
to
extra coating inside that the tube as well.
Yeah, exactly. So just to want to show you some of latest tests we made, and I'm showing you one patient that have very, very low basal platelets count, 188, and after a single spin, because this system, the other very nice thing is needs only one centrifugation, so it's very, very easy, very fast, and after one spin you can we obtain in these patients with this low platelets value, basal value 188, after hyperconcentration, we discarded 9 ml of poor plasma platelets, and we keep 3 ml of platelet-rich plasma. We have a concentration of 1 million and 2,700 platelets per microliter, and when we calculate the dose, so we obtain 3 ml, we obtain 3.2 billions. That is really quite a lot, starting from this very low basal platelet count. In these patients, with this basal count, we have to use 2 tubes.
Okay, so you use
Another
222 mLs
patient
on this patient.
Another patient on the high level of basal platelets concentration, 330 is the basal, 1 million, more than 1 million. Again, here we have the right platelet dose, 3.9, almost 4 billions. On this patient, you can also use only one. So how much blood you should draw to obtain the PRP minimal clinical dose? That is at least the minimal clinical dose, it seems to be 3.54 billion. So if we just make a very, very simple calculation, in average, if you have a patient with 200,000 platelets, how many billions you will have in 10 ml of blood? You'll have 2 billions. So every system that starts with a blood volume of 10 ml of blood is too low to reach 4 billions. It's impossible. So at least you need to draw 20 ml of blood. It works with a recovery rate, the 100%, that there is no system in the market, it's not possible to have a recovery rate of 100%. What it means, the recovery rate, the recovery performance is the percentage of platelets you recover versus the platelets you'll have in the blood of the patients. So,
Yes.
okay, the concentration factor in our test from 188 to 1 million, it's a 5-fold higher than in the baseline, okay? But we also have a very good dose with this low level, that is 3.2 billions of platelet, and which was our recovery was very, very high, because the platelets we have in the 20 ml of blood from the patient of the patients was 3.76, but we reach 3.2 in our PRP. So this is the 85% recovery rate. So that means that our system, it works well. Regarding the bioformulation, always from these two tests we have done it. As you can see on the left, there is the first patients with the low basal counts, 180, and on the right, the patients with 330 platelets at the baseline. And you can see that when we are looking white blood cells, to check if this system was really working like the claim of the producer. So it's really a leukocyte-poor rich plasma. It is, because from 10.5 you go to 1.5 in one patient, and from 8.7 you go to 2.6 in the second patient. But the important thing is, if you are looking on the neutrophil white blood cell population, as you can see, is very low, is 0.2 in both patients, but are still in together the platelet dose we recover. There are mononuclear cells that are at the physiological concentration we have in the blood. Together, no red cell contamination. So this is really interesting bioformulation for a PRP. Another 2 points, and I think I'm quite finished, because why it's important to have a buffered anticoagulant at a physiological pH. It has been showed, published a lot of years ago, in 2009, that the proliferation of resident mesenchymal cell have been shown to be 5 times more in PRP when PRP is not activated, is not pre-activated, and when it's buffered at a physiological pH 7. We have to keep in mind the mechanism of action of PRP, that it's based on the release of growth factor and cytokines and chemokines and exosome and so on, but all these active release molecules will interact with the cell-cell interaction or like the paracrine effect to the other cells, other population of cells that are resident in the tissue. Also with the stem cells that are resident in the tissue, because we have to keep in mind that in every tissue there are some resident cells that just stay there, and we can activate them through the release of growth factor and so on from PRP. So it's important. This data is very, very important. And the other critical issue is it's better to pre-activate the platelets, the PRP, before the injection. Activation, it means add calcium, basically, or thrombine, autologous thrombine. Here again, there is this paper that help us. It's shown that the effects of the activation of PRP on bone regeneration in this case is not the best thing you can do, because in vivo and in vitro the pre-activated PRP reduce chondrogenesis and osteogenesis instead of increase. So that's one of the reasons, as a scientific director, we decide never pre-activate our PRP. It will be a physiological activation when you inject the PRP intra-articular or in the muscle or in the tendons. It will be a physiological, very slow activation, and all this, the growth factor and so on, will be released in the tissue of the patients, not before. So here, just a brief summary of all the characteristics we have seen. It's important, I believe, that the single spin, it's also important because preserve the paracrine release. Every time we spin, we centrifuge platelets or cell, the cells, then the platelets will start to release what they have. And so they don't want this. We want to have the release in the patients, in the damaged tissue, not before. And here the procedure that is very, 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 very simple and easy. And I think that's the point. And the take-home message I would send with this presentation is exactly the title of this paper published in 2002. Would you have an injection without knowing its formula? I think that every surgeon and every patient have to know this. Which kind of injection I will have? How many platelets? There are leukocytes, there are red blood cells. And I think we have to work on that to have a better standardization and to have better results on our patients.
Interesting. So going back to that paper that you just showed, um, for someone that is, that would like to integrate PRP, regenerative medicine, into their practice, right? Um, what would be some advice that you would have for them in regards to, specifically that paper, right? So what is your protocol? Like, what do you do, in your clinic, and that would help you obviously understand that?
With all our center, with all surgeons that work with our system, we start to do this honestly because our Italian law oblige us to do it.
Hmm. Okay.
So
Hmm.
every in the hospital, out of the hospital, um, we need to prove, we have to work in collaboration with the transfusional center. We need to prove which kind of PRP we are producing. We have to make tests every time. Okay,
Wow.
so we were obliged to do that at the beginning, but we realize it's a big opportunity on the
Yes.
other because we can, we always know what we are doing, which kind of PRP we are injecting, how many platelets we are injecting, and so on. And so also surgeons and patients start to realize how important is to know which kind of PRP, what is the procedure, what is the
Wow.
recipe of the
Yes.
autologous
Yes.
products they are treated.
Yeah. So here in the in the U.S., we have the FDA, right? What organization do you guys have in Italy that kind of
We
fits
have
in
no,
their
so we have for the certification we are European, so we have the I don't know why I can't see you anymore. Okay. Um, we have now you every device you need the CMARC certification. Recently, this law changed from the old C certification to the new one, and the name is CMARC under the MDR regulation. This is very, very similar to FDA, very similar to FDA. So all the devices, when the old C certificate expire, they have to go through a recertification, basically, this this new regulation. So this is very, very big change for Europe right now. So notified body are very, very are doing lots of certification of all the medical device in the market right
Yeah,
now on this. So the quality is really, really important.
and you guys are passing that through with flying colors, I'm sure.
Yeah, Tropocell Esther have gone through this new certification, and they start 2 years ago to do this.
Wow. Okay, that is very interesting. So thank you very much for that. So I do have a question, right? So there's regenerative medicine. Obviously, you said that you've been in regenerative medicine since 2022. It's been a very long time. So I'm sure you're well experienced in this topic. Um, for someone that is looking to integrate PRP in their office, right? Obviously, there's a lot of noise. Out there, in regards to what PRP system to use, how much blood to draw. And you did a very good explanation, in this presentation. But if there's a physician that's getting started in regenerative medicine, what advice would you give him? What type of protocol would you have him would you advise him to do? Um, yeah.
Make test, make test.
Okay.
The good things with PRP
What does
that
that mean, test? What does that mean?
I mean make a blood count before and on the PRP they obtain. So it's very basic, very
Yes.
basic. Almost all of them can do it, or they can work, in collaboration with a lab to do it. So just do it.
Got it.
Just do it.
Okay.
Be sure, make the test, verify which kind of PRP you are using. And you can do it also, you can do it every time, you can do it sometimes, you can use the test to test new medical devices that are entering the market. So everyone can have his own experience on this.
Okay. Okay. Well, yeah. Another question that I have for you. So, what are your thoughts on the potential synergies between PRP and other regenerative therapies, right? Such as stem cell treatments or tissue engineering approaches. I did
Yes,
see that on your LinkedIn. You have some experience in tissue engineering. Would you like to share
yes,
a little bit with
yes,
us?
yes. It's a very interesting combination to use PRP with some scaffold or biomaterials. We have an experience on a dermal substitute, so in skin regeneration, in wound healing area, in the wound healing area, because this matrix, that is collagen, it's the repopulation of the collagen with the cells of the patients. It's much more, it's faster, and the tissue that it will be created, regenerated, is much more physiological, very close to the dermal tissue of the patient, if you are using this collagen scaffold plus PRP, plus the growth factor. This is one of an example of a basic tissue engineering that every surgeon can do in this OR or in this ambulatory. So there are two medical devices, two certificate medical device. So you don't need to go to a cell factory or a very complicated and expensive tissue engineering, also if in some area you have to, but there is this possibility on some clinical application, and to do it in very simple to get a better results. And it's a very, very interesting field, and we have we, we have to study a lot to really understand how this growth factor can be combined with different scaffold. Basically, the idea is to have a slower release of growth factor, because one of the problem of the growth factor that they have a very short life. When they are released, VEGF, vascular endothelial growth factor, when it's released, when it's out, the platelets will release all the VEGF from the alpha granules. They will stay for 2, 3, 4 minutes.
Wow.
Very short lives. Some other, it will stay for 2, 3 hours, 4 hours. So if you can combine this with the scaffold, with something that will keep there and will release very slowly, in some application, you can have a much better clinical outcome. In wound healing, it's like this. Platelets stay alive and will release for at least from 5 to 7 days. So better to have lots of platelets alive. We are not damaged the platelets during the procedure, and they will release in days, very slowly, little bit. And to have this longer induction of biological mechanism in the tissue for days instead of minutes or hours.
Okay, that's a very interesting take. I have one more question for you. So based on your experience, right, in regenerative medicine and PRP, obviously you've been, in regenerative medicine since, 2002. Where do you see yourself, where do you see regenerative medicine in the next 5, 10 years?
I have a quite clear idea about this because in these 22 years, I work with
Yeah.
lots of different PRP, bone marrow, adipose tissue, stem cells, scaffold of every kind. And in 2012, we start to work with peripheral blood mononuclear cells. And honestly, the results we have seen with this new cell therapy goes under the name of immunocentric revolution are really, really impressive. This therapy is well known right now, almost only in Italy. In diabetic foot critical limb application, critical limb ischemia, we have treated more than 4,000 patients with this
Wow.
therapy. We will start to move also in musculoskeletal disease at the end of the year, and I really believe that this will be the revolution of the regenerative medicine in the next 2, 3, 4, 5 years.
Wow. Okay, so that's around the corner.
Yes,
It's around the corner.
it is.
Yeah. Yeah. Okay. Well, Laura, thank you very much for your time. Thank you very much for the valuable insight that you provided us. I'm really looking forward to the future of regenerative medicine and hear what you have to say with all the research and everything you have going on with Athena. Do you have any final thoughts? Anything you would like to share with us before we end the interview?
That was really been a pleasure. I hope this presentation will be interesting and helping lots of people, to go deep in this very, very fascinating world of the regenerative medicine and PRP. And thank you, Oscar. Thank you so much for your invitation. I will be happy to do it again in the future.
Yes. Yeah, we will definitely do it. We will. I know there's a lot of topics. Science is always moving fast, and we can get deep into it and spread awareness and move forward. Regenerative medicine is the future. That's what I
Yes,
always say, and that's why
absolutely.
I love regenerative. That's why I love regenerative
Absolutely.
medicine. Yeah,
Yes, I completely agree.
yeah. Well, thank you very much. You have a
Thank
beautiful day.
you.
Okay. Okay.
Thank you. Bye. See you next time.